Good morning. Here I am again. And again, I had about 150 slides, but I've reduced them in number, and I will skip during the presentation. Because I was asked to answer the question how I do it. Manometry and pH impedance monitoring. Well, and the easiest answer to that question is that I don't. I usually don't do manometry and pH impedance monitoring. I have it done by somebody else. As you can see here, this is a different person from me. You can see he has a different hairdresser. And so in our laboratory, all pH and manometries are done by trained nurses and physician assistants. And they do it much better than we would ever do. For those of you, this is a high-resolution manometry going on, but for those of you who wonder what this is, it's a puller device that we use to keep the catheter in place. It's not absolutely necessary, but most of us find it handy. Now, first about manometry. If you don't have high-resolution manometry, there was a question in the previous session, then you are not lost. I mean, you can still do all the good work that we used to be able to do before the advent of high-resolution manometry. You can see the peristalsis, and you can make all the diagnoses like achalasia, and that you can with high-resolution manometry. You can even identify achalasia type 1, 2, and 3 in conventional manometry, if you know what to look at. And nowadays, most people are switching to high-resolution manometry. You can do that with a perfused system, which is a bit more cumbersome, but cheaper. Or you can do it with a solid-state catheter. And as I said in the previous session, we have completely switched to high-resolution manometry with solid-state system. And I'm sure you're all familiar with what you can see under normal circumstances and under pathological circumstances. And you're all familiar with the new terms that you have to know if you analyze high-resolution manometry. Distal contractile integral, which is a measure of the contractile activity, and distal latency, which is a measure of how soon the esophageal contraction occurs after a swallow. And then you know the integrated relaxation pressure, which is a measure of relaxation of the lower esophageal sphincter. As I said in the previous talk, with the advent of Chicago, the classification has changed, but basically the diseases are, of course, still the same. And as I explained in the previous talk, you follow the hierarchical analysis scheme shown here from top to bottom, and then you automatically arrive at the diagnoses. What I did not yet mention is that you can see hiatus hernia as a double high pressure zone. Here is the LES, and here is the diaphragm. And one has recommended that you'd call it type 3 if there is a hiatus hernia larger than 3 centimeters. We are not so very fond of that. We just say we see a hiatus hernia of 2 or 4 or whatever centimeters. What we also do during a standard manometry is not only giving the 10 wet swallows, but also make so-called landmark period recording in which there's no swallows and at least 3 respiratory cycles. And this can be used to measure the old-fashioned LES pressure, which is not in the Chicago system at all. And you can also measure a new thing that is the contractile integral of the esophagogastric junction. These are still quite experimental, and we don't use them in any clinical care, but they are there in the system for one day a new PhD fellow will bake a cake out of this. What we also do nowadays is doing the rapid drinking challenge. That is giving 200 mL at the end of the investigation. We let the patients drink this if they can. And we also don't know what to do with it yet. We don't use it clinically yet, but it is for future reference. It has been shown by this study from Spain that normal subjects do not have a buildup of pressure in the esophagus during the rapid drink challenge test, but people with mild obstruction or severe obstruction, they have a buildup of a pressure in the esophageal body during this drinking. Another test that is being done by other people, but not by us, is doing the multiple rapid swallows, which is 5 2 ml swallows. And this is basically thought to look at the peristaltic reserve, that is the peristaltic contraction that is following this inhibition. Still, I think this is in the research domain, and we don't know yet how useful this all is. And we certainly don't do any solid manometry, using solid boluses. I also told you that we have this equipment and use it sometimes for combining impedance manometering with impedance measurement with manometry. But again, we don't use it in clinical practice. It is not incorporated yet in the Chicago classification. So far about how I do, or we do, manometry. Now about pH impedance monitoring. As you all know, you have catheter-based pH monitoring and capsule-based, where it's a radio transmitter clipped into the esophagus that does the work. Patients like this one better, but the hospital liked this one better because it's cheaper. So we mainly do catheter-based pH monitoring. Only when the patient doesn't tolerate the catheter, we switch to capsule. Then it shows here pH-only monitoring, and that is basically what we don't do anymore. It's usually all the times combined pH and impedance monitoring, what we do in our hospital. But to keep life simple, I would like to stick to pH only for a while and tell you that in the part of, in addition to esophageal acid exposure, a very important parameter is the temporal association between symptom episodes and reflux events, which can be expressed as the symptom index or the symptom association probability, which I learned here in Spanish-speaking countries is called PAS or PSA, I forgot. Anyhow, the letters are in a different order. Using these two indices, you can divide the patients with reflux symptoms into 4 groups. Those who have excessive acid exposure and a positive symptom association, and they are very likely to have GORD or GERD. You have patients who have physiological acid exposure, but have a positive symptom association, and these are now called reflux hypersensitivity, according to Rome 4. Then you have patients who have excessive acid exposure, but a negative or not positive symptom association. And you may argue that they have GERD, but it seems that their symptoms are not caused by the GERD, by the acid reflux. And if they have esophagitis, you can call them GERD, but if they don't have esophagitis, you probably shouldn't call them GERD. And then there are patients who have physiological acid exposure and a negative symptom association, and these are usually labeled functional heartburn, as you all know. In the new Rome classification, functional heartburn and reflux hypersensitivity are listed, and To make a story short, functional heartburn is when there is no evidence that the symptoms are related to reflux, and the reflux hypersensitivity is when there is evidence that the symptoms are triggered by reflux, but acid exposure is normal. Now we go to the combined pH impedance monitoring, which, as I said, is the technique that we use routinely, catheter-based. And then the question is, does this require cessation of the PPI use, or can you measure on PPI? The question has been answered many times by different people. We think that it is mostly best to do it off PPI. Why do we think that? Well, this researcher in our group a long time ago, almost 10 years ago now, studied 30 GERD patients off one day and on another day, randomized order with a washout period in between. And as you can see, the total number of reflux episodes that is measured with impedance, so that's all sorts of reflux, acid and non-acid together, is not diminished by giving a patient a PPI, but on PPI, most of the reflux episodes are non-acid, have a pH above 4. This same person also studied the symptom index on and off PPI in these same 30 patients. And it was found first that more patients had their symptoms, let's say heartburn, regurgitation, during the study when they were off PPI, 28 versus 23, and more patients had a positive SAP than when they were on PPI. And this makes it the chance that you can identify the presence of GERD, you can prove that the patient's symptoms are really truly based on GERD, is higher when you measure them off PPI. Now, most recent guidelines says that you should use off PPI when you have not yet proven that it is GERD, but when there is proven GERD, that you should use on PPI. We don't fully agree with this. If you have proven GERD or think you have proven GERD, then you're still free to do it off PPI, and you will still have a better chance of finding something. This is what you measure, what you find if you have patients who are supposed to have GERD, are treated with a PPI, often in high dose, but are not very satisfied with the result. Then you see that the majority has GERD, and quite a group, this one here, has reflux hypersensitivity. So they have normal acid exposure off PPI, but they feel their reflux very well. This chunk here, the 30%, is very worrying. That is, of course, the functional heartburn patients, and these have nothing to do with reflux at all. And you can increase the dose of PPI or use a PCAP or whatever, but this patient group will never be satisfied with the treatment because they don't have GERD. And that is the importance of measuring pH impedance in patients who are not satisfied with the response to treatment. Now, I'll skip a few slides. I think you will like that. I have a case. That's something else. We'll have more cases, I understand, but this is one. A patient of 64 years old who had heartburn and regurgitation and some belching. She has a hiatus hernia, but she is not satisfied with the omeprazole or the esomeprazole. She's overweight. Now, I show this patient because it's a real patient, and I show you why I believe it's so important that you do these studies properly. She had a manometry that showed hiatus hernia and reasonably preserved peristalsis. And we did a pH study, and she had pathological supine and upright acid exposure. But then the most important part is, of course, the symptom association analysis. And for this, we instruct the patients very carefully before they are sent home with the equipment. And we give them this diary. This is in Dutch, but I'm sure you can understand it. This is diary, ambulatory measurement. And here are the periods of eating and drinking. And here are the symptom episodes noted by the patient in her Dutch writing. And many of these are zuurbrand. And zuurbrand means heartburn. And there are also a few hoest, that is cough. Yeah, that's correct. Difficult, yeah. I will not go no further. This is it. Don't worry. So she mainly has zuurbrand, which is heartburn. Then we go and look at the tracing, and then the equipment selects for us. This is the moment that she pressed the event marker button, and this is a 2-minute window just preceding this event marker. Onset, and this was an episode of cough, and we see nothing that looks like reflux in this 2-minute window. Now I jump to the next reflux, the symptom episodes, which was heartburn, and here we see a clear-cut acid reflux episode. And number 3, also reflux acids here, and 4, and 5, and 6, and 7, 8, all acids reflux associated, and 10, and then there is another cough which is not associated, and another cough not associated, and another heartburn associated with acid reflux, and so on. 15. So 12 out of the 12 of her heartburn episodes were preceded by reflux, which gives her a symptom index of 100 and a symptom association probability of 100. And people who don't do this analysis, they don't wish to see the beauty of it. If you have a patient like this, then you can be sure that the patient's symptoms have really are caused by reflux, and she might perhaps be benefited by an anti-reflux procedure. In this case, we said no, you just come back if you have lost more than 30 kilograms, and we'll talk again. I have 2.5 more minutes for the second and last case, just to show you another, no, I will skip this one, so sorry. This is the case. This is a patient whose main symptom is belching. And he has survived this for more than 10 years, so it can't be very serious. But he wished to be helped, and we see the 24-hour recording, and nothing much very conspicuous. But if we zoom in at certain episodes, then you see these events here. This is a 30-second episode out of his life, and then you see the typical characteristics of the supragastric belch. You see air going in and going out immediately thereafter, and it is called supragastric belching. This is another example where the supragastric belching occurs during or at the onset of a reflux episode, and this is another example where he shows the same phenomenon. Here, we think that the patient may be helped in some cases by referring him to a speech therapist. We have collaboration with speech therapists who dislearn the patient to do the supragastric belching, because supragastric belching is a behavioral phenomenon that you can unlearn. But this is partly in the research domain. It still has to be proven in larger series that it is helpful to treat patients with this condition with behavioral therapy. I have 44 seconds left, and I would like to use these to draw your attention again to the meeting in Amsterdam, and to thank you very much for your attention.